We're thrilled tonight to have our colleague, Dr. John Ragged, moderating tonight's session, and he's promised to share some of his insights on Haiti during the Q&A afterwards as well. He's picked out a fantastic panel of speakers for us tonight that he's going to go ahead and introduce, and I'll just give a quick reminder to everyone, please write in your questions during the talks, and we'll try to include all of your questions during the question and answer discussion portion after the three talks.
Thank you, Drs. McRae and Niazi, for allowing us to do this. It's really, it's my pleasure and privilege to be part of the symposium today. You know, I've been pestering them for probably 6 months or so to do global surgery as a topic. I think it's gratifying to see neurosurgery and pediatric neurosurgery in particular leading the interest among neurosurgeons in the field of global surgery. And for those that have been involved for a while, like Dr. Green and myself, it really is a pleasure to see so many people interested in trying to help beyond our borders. So we have three great speakers today, and the goal of which is to talk about the spectrum of global outreach and specifically global surgery. And we'll get to the pediatric part in the end in the Q&A. So we have three great speakers, Dr. Barth Green, who's the chair emeritus at the University of Miami and the executive dean for global health, Dr. Key Park, who is a neurosurgeon and runs the advocacy and policy for the Center for Global Surgery at Harvard, and Jim Johnson, who's a pediatric neurosurgeon at the UAB and was a principal in the development of Intersurgery. So we're going to start with Barth in the broadest talk, and then Key, and then Jim, and there'll be plenty of time for questions. As Heather points out, please write them down. We'll give you, and we'll try to get to all the questions. So I'll stop talking and let Dr. Green take over. Barth, thank you so much for doing this.
All right. I think the most important word on this first slide is opportunity. And that's what global health, global surgery, disaster response, all the things we're going to talk about. It's really important for all of us as healthcare providers to take advantage of these opportunities. And this is my own little path over the last 50 years of where I've worked in various countries of the world in global health and global surgery. And these are my teammates, many of whom are on the phone today, because you're not really effective if you're not part of a community. And it really does take a community, a city, a group to be successful. Project Medishare was an example that I'm going to use tonight of a way that we started a program in the most underserved country in the Western Hemisphere, and we're able to create sustainable healthcare and a good quality of healthcare at a very low cost, and been able to not only maintain it, but to see it flourish over the last 30 years. And so today, I'm going to give you just a very brief where we were and where we are about Haiti and share some of our experiences in both the positive and negative sense. Many people know the history of Haiti. It started out as an amazing cultural land of opportunity and ended up after the revolution and independence as a real issue with regards to governance and the way the country was handled by the international countries. And there's no sense pointing fingers because today we are where we are, but it is the poorest country in the Western Hemisphere. Over 11 million people, 98% living in poverty and below poverty. And healthcare is really not a priority. It's less than 2% of the national budget. And you can imagine in a country like Haiti that not only faces the normal diseases and injuries, traumas, cancers, but also has a myriad of pandemics and disasters, earthquakes, tornadoes, hurricanes, that this is a challenging place, but a most rewarding place to work. Project Medishare was started because I fell in love with Haiti on a mission trip in 1990, and I fell in love with the people and their spirituality. And today this program has grown that we're treating over 200,000 people a year between our rural programs in community health and maternal health and orphans and vulnerable children and school feeding in the rural plateau and running a trauma center, critical care center in downtown Port-au-Prince. And the primary goal from the beginning was to establish infrastructure that could be sustainable. But it's very difficult to look with an honest face and say that we've got a program that's sustainable without philanthropy. And I'm not sure of any program in any developing nation that's sustainable based on revenues of that program without strong government or philanthropic support. We had a real wake-up call in 2010 when within seconds, 300,000 people died. And when I say people died, I'm talking about the leadership of the government, the United Nations, the medical schools, the nursing schools, the police forces. Everybody was, because it was during working hours when this occurred. And this is an example of the palace. Luckily, we were able to arrive the next morning with a team from Jackson and and were able to establish a base at the airport where we were met by the president and handed him satellite phones and opened up his communications to the world. But we also were doing amputations on kitchen tables without any anesthetic and went through a very, for myself, even though I've spent my career in global health and community service, it was quite a shocking experience starting from day one. But within a week, because of the community in South Florida, we found ourselves in a 300-bed tent hospital at the airport with generators, air conditioners, laboratories, imaging, operating rooms. And during that period of 4 months, we treated over 30,000 patients, several thousand surgeries, and became a staging center for all the recovery efforts in Haiti by the US military and other international forces. And it was an amazing thing to be part of, but people on this seminar were also there, including Dr. Ragab and others, contributing to this amazing effort. And you can see this was not an easy challenge to overcome. But the most important thing is that the world stood up and said, we're going to do something about it. We're not going to accept these deaths without doing something different about it. We're going to try and change things. And that was the beginning of a lot of new opportunities and programs. And we were literally forced out of the airport, 10 hospital, in about 4 or 5 months after. And we moved to a community hospital, which became our new trauma center, Hospital Bernard Mev, where Dr. Ragab had really pioneered bringing surgery for hydrocephalus and spina bifida and pediatric abnormalities to a country where such surgery did not exist. 11 million people, one fully trained neurosurgeon, who ironically now is the acting prime minister of the country, but he leads our training program at Bernard Mev and our fellow in residency program. So this is where we started. And again, everything was gone, and it's just hard to describe. And I have a beautiful video, but not time to show it. But today, Bernard Mev has been transformed into what I would consider a Western equivalent hospital with operating rooms and the only hospital in Haiti with ICUs for newborns, for children, and for adults. And with the ventilators and critical care doctors and nurses and ancillary staff that are now almost all Haitians, that would be unheard of when this occurred in 2010. There were no ICUs like this in Haiti, and there were no critical care physicians. And when I met with the community physicians prior to the earthquake, trying to create a plan for trauma for the country, I asked, what is your highest priority? And they said, teach us CPR. And so that tells you kind of where we started. But today, Dr. Raghib and his team of pediatric surgeons and colleagues from all over the country travel to Haiti and do these surgeries in this hospital, which I think is an amazing place now with its own pediatric and newborn units. And it's the most important thing is it's staffed by Haitian doctors and nurses and allied health professionals that just didn't exist before the earthquake. And this is a problem. I'm going to talk about some of the things that we faced and the recent chaos and social unrest that has to do with a lack of government and a lack of any peace and order and any justice system. And again, Bernard Mev, being a trauma center, has been overwhelmed. And in Haiti, there's many reasons that people take to the streets and that you see this type of demonstration. But because of living the last 30 years in this environment, we've learned some very hard lessons. And I want to share with you some of the amazing positives that have come out of this. There are 5 medical schools in Haiti, and these are courses that were taught by our residents down in Haiti. And you can see the hundreds of medical students who attended these courses and who participated in the education and training and capacity building, which is a major goal. And one of the things we learned is that it's a privilege to be a nonprofit, an NGO, and it's very important not to overstep. And that's the problem. We often describe Haiti as an island of entitlement floating in a sea of NGOs, because most of the faith-based NGOs, not all of them, have their own agenda. And if you want to eat or go to school or get clothing, you have to become a Baptist or a Lutheran or a Mormon or whatever it is. And, you know, Medishare is not in any way have any agenda like that. But you have to realize that the country by USAID was divided up by religion, by these different NGOs. And that's a problem. It's important that if nonprofits want to have the privilege of working in a developing nation, that they realize this is a privilege. They have to be culturally sensitive, and they have to work under the mandate of the plan of the Ministry of Health and not try and create their own plan. We did a lot of bad things, for example, by bringing in 5,000 doctors and nurses and doing thousands of operations and giving away hundreds of tons of medicine supplies. We bankrupted the healthcare system in Port-au-Prince. All the doctors and nurses and pharmacies went out of business because everything was free if you went to the airport. That's a lesson we learned. You have to be sensitive. And we didn't incorporate the local community and train them. And from the very beginning, which we finally did, but it took us a while to get it, which is something that's part of the education of global health. Don't make promises you can't keep is another one. And a lot of times people are offered jobs or opportunities or facilities. And if you can't finish something, you shouldn't start it. It's very important. And there's no sense bringing in volunteers. And we all talk about how wonderful Doctors Without Borders are, but it's important to train local physicians and nurses, not to just go in a crisis and then leave when the crisis is over, but to create sustainability and build capacity and leave behind people who are capable of taking care of their own people. And that's very important. Sustainability, capacity building. And again, the mistakes that we've made and the mistakes that the government made are things you have to really understand. And there can be zero tolerance for what is unethical or illegal in this country. But in other nations, borrowing some gasoline from a tank is acceptable, you know, if you work at an NGO. Another thing is donated equipment. People sent us tons of vehicles and supplies and scanners, and they all broke. Never accept used vehicles or equipment in a developing nation. Start with new equipment, even if it costs more. It's not gonna end up being part of the junk pile or part of the contamination of the earth. These are all important things. So what did we decide to do? We decided to create that trauma center we thought about before the earthquake occurred, and we designed it with help from Washington University in St. Louis and other groups. We came up with a design for a critical care and trauma center. We located it on purpose in the poorest area of the poorest country, what's called City Soleil, on a large property, and we started building it. And we now completed the construction of the shell, but because of gang violence the last 6 or 8 months, we haven't been able to staff it or equip it fully. But the idea was a national system with every department, there's 10 departments in Haiti, having level 2s and having a level 1 or a national center in Port-au-Prince, which would be a public-private partnership. It would be sustainable based on revenues from the 2%, the private sector, who would support this rather than flying to Miami or to Boston to get a PET scan or a CTA, which are not available. There's no such thing as a radiation therapy machine in Haiti. There's no such thing as interventional radiology or an angiogram, not one angiogram machine for 11 million people. So this is the design of the center. We've already built the shell, and we're just waiting for the civil unrest to calm down. And right as part of this center and complex is a major educational center where we can build capacity locally and nationally in all areas, not just critical care, trauma, interventional radiology, and trauma surgery, pediatric surgery, but also in allied health professionals. And actually 50% of the 160 beds in this center are pediatric, because the pediatric patients are a major population challenge in Haiti for healthcare. So this is what it's all about. Being a global health surgeon in a developing nation is a lot more than doing surgery. It's about dealing with catastrophes, pandemics, earthquakes, hurricanes, but also dealing with the government, dealing with all the other issues that allow you to get distracted from your goal. So this is where we are today with Corona. Project Medishare, even though it's not a health MSPP facility, we're now giving vaccines along with the Ministry of Health, both in the Central Plateau and in Port-au-Prince. But people don't want vaccines in Haiti because of the anti-vaccine rhetoric on TV. So we've created a program where we're giving away mosquito netting to everybody who gets a vaccine as an incentive. And so that's what we're doing now. And we're very excited about it. Again, every program that we've created has made a difference. It saved a life. It saved many lives, and we're just starting. But today, there is no problem with maternal death and neonatal death in the plateau with our 2 maternal health centers. We've eliminated it as the #1 mortality center in the hemisphere. So this can be done at a very low cost. And that's why we're here today, to talk about the opportunities for each one of you to make a difference by serving your neighbors, not only in the United States, but globally. So making a difference is the best way for you to be happy. And again, somebody who's never made a mistake has never tried. Thank you very much.
Thanks, Dr. Green, for that inspiring talk. It's hard to imagine summarizing all of that in 20 minutes, but really phenomenally inspiring. And I think there's a bunch of key words in there that we're going to talk about at the end in the question and answer. I particularly like the comment about ask what people need and then be sure to listen. It's such a simple message. So thank you so much, Mark. We're now going to hear from Keith Park, who's part of the Global Surgery Center at Harvard and an authority on global surgery overall. He's really helped crystallize the world's view of the gap in global surgery and has been instrumental in developing strategies to address it. So we're really looking forward to hearing Keith. So I'll stop and look forward to you talk, Keith. Thank you so much for doing it.
Okay, great. Yeah, thanks again to John and Heather for inviting me. It's a privilege to be part of this panel, and of course, Dr. Green's talk is always inspiring. I'm looking forward to James Johnson's talk. Now, if I understand correctly, John and Heather wanted me to talk about where we are in overall global surgery, and then maybe to make the link between global surgery and global neurosurgery for this panel. So, I mean, the University of Miami has been doing amazing work even before 2015, for three decades. But in 2015, something happened. There was a report from the Lancet Commission on Global Surgery that highlighted and quantified the magnitude of the unmet surgical needs in the developing world. At the same time, the Disease Control Priorities, it's a World Bank publication, also published its third edition with the first volume entirely on essential surgical care. So there's just a few numbers to get us started. 5 billion out of 7 billion people in the world do not have access to timely and affordable and safe surgical care. That's more than half the world. And about 143 million operations are unmet, not done when they need them. So these are mostly in low and middle income countries. And then if the governments fail to build up surgical care to treat these patients, there is a loss of GDP over the next 15 years of $12.3 trillion. So these are massive scale numbers. So based on these two reports, and there was a political event. Annually, there's a World Health Assembly that's held in Geneva, hosted by WHO. And there was a resolution put forth by the Zambian mission calling for strengthening of emergency and essential surgical care as a component of universal health coverage. And this is really where I think the global surgery movement really took off after 2015. And the reason for that is that we've shifted from this kind of a mission model, training, specific skills, more equipment, to a broad system level changes is what we were calling for, a health system change, surgical system change. So there's 6 components of a health system the WHO calls the building blocks. Service delivery, that's the patient care aspect of it, human resources, medicine and technologies, financing, information management, all put together by a competent managerial and governance structure, without which you can't really have a sustainable change in the surgical system. So if our vision is universal access to surgical care, our strategy is to really strengthen global surgery systems. And then we have to work directly with ministries of health. That's who our main counterparts are now. And we want them to develop strategic plans to scale up surgical subsystems as part of the overall health system strengthening. And so Harvard Program in Global Surgery, we are the official WHO collaborating center for surgical system strengthening. And so we work closely with ministries of health. We engage with development finance institutions like the World Bank, ADB, other banks, and try to convince them to invest in surgical care as well. So one of the key things that came out of the resolution was the WHO's inclusion of 6 surgical indicators in their annual WHO's 100 core health indicators. But there's a saying, right, where what you don't measure you just can't get done, right? You have to measure it to get it done. So we're tracking these surgical indicators, things like perioperative mortality rate, 2-hour access, surgeon anesthesia densities, and of course the very important financial risk protection. How affordable our surgical care is quite important, and WHO tracks that. So there's a process that goes through by the Ministries of Health goes through the multiple steps. And number one is political will. So that the WHO resolution really provided the political will. And then there's an initiation of a broad stakeholder engagement. So a country like Haiti, University of Miami would be at the table for designing a national surgical plan for Haiti because they've been a long-term partner. So NGOs, Ministry of Health, surgeons, professional societies, nurses, anesthesiologists, all these groups come together and come up with a vision for the country, set targets, it's costed, it's financed, and it's implemented, and then there's a monitoring evaluation mechanism. And this is all been written up in a manual. We've got now a second volume of this. It's a manual for national surgical planning, and this is the first volume. A second one was just released, and feel free to contact me, and I can send you the free download link to the manual. This picture is from 2 years ago in Manila. So WHO has multiple regions. This happens to be the Western Pacific Regional Office, about 34, 36 countries in the region. And the picture to me is so inspiring because global surgery movement is not being led by global health people. It's being led by surgeons, anesthesiologists, and other advocates that are actually parts of ministries of health. So the Minister of Health of Fiji is actually a surgeon. The Director General for Health in Malaysia is a surgeon. And Tonga, I think, is an anesthesiologist. So you've got all these people who are, sort of our insiders working at these, at the policy level and ministries. And so the global surgery movement has been really helped by these advocates that are championing it in their countries and also regionally. So here's a snapshot of all the countries that are involved in surgical system strengthening, national surgical planning process. So as you can see, a number of countries in South America is an initiative within the Caribbean community. I think 12 or 13 English-speaking countries in the Caribbean. I think Haiti may be even part of it. It's being driven by one of our fellows, Myron Roll, and its idea is to cooperate and strengthen surgical systems, beginning with basic neurosurgical care. If you look at Africa, number of countries actually finished the process and now of planning, and now they're implementing it. There's Ethiopia, Nigeria, Zambia, Tanzania. But if you look at the southern tip of Africa, it's all blue. And that's because there are 16 countries in the Southern Africa Development Community, and all the health ministers of these 16 countries came together and decided as a group, let's go ahead and strengthen our surgical systems, and then we'll start with national surgical plans. In a similar way, in the Western Pacific, as I mentioned, 33, 34 countries came together and said, let's go ahead and initiate a regional surgical system strengthening initiative. It's called Safe and Affordable Surgical Care. They don't use national surgical planning as a name, it's more of a framework. And a lot of it was driven by the SPC, Southern Pacific Community, with health ministers coming together, some of them being surgeons and anesthesiologists, and saying, we want to do this as a regional block. So, we used to have these workshops for ministry people in person in Dubai. That's come to a halt because of the pandemic, but we continue to do webinars and training virtually. And we've had most recently a couple of webinars with the regional offices in Western Pacific and Southeast Asia with Poonam Singh and Takeshi Kasai. And we also, World Bank is a very strong partner with the financing of surgical systems with the Global Financing Facility. And this is really interesting. USAID is the US government's largest overseas development assistance program, and they have a global health portfolio. And we've been able to convince the senators and members of Congress to include language that mandates the USAID administrator to support surgical system strengthening in the national surgical planning process. And right now, they're in debate about how much money should be allocated. So this is last year's language. It's already in there, but there was never a dollar amount attached to it. Now we're trying to get $100 million attached in the language, similar language, but saying U.S. administrators shall support and spend no less than $100 million. And I got to tell you, Marco Rubio, your senator in Florida, is one of the strong supporters of this language and the $100 million allocation for this. So what this means is that if we get money from USAID, ministries of health that are trying to scale up surgical services can start writing for proposals that could access these funds. And these proposals would be projects designed to strengthen, let's say, district level hospital or regional hospital or health system, but it should be included and integrated into the overall national surgical planning process. So now we're going to switch gears to global neurosurgery. And once again, there's there's a serendipitous things that happened as we go. So WHO, once the resolution was passed, they hired a person to implement the resolution 6815. That's the gentleman in the middle here with the white turtleneck. That's Walter Johnson, and he's actually a neurosurgeon. And so, he's overseeing the surgical scale up from the WHO headquarters, but he's also trying to figure out how does he get neurosurgeons to come together and then scale up neurosurgical care. So myself, Walter, and Bob Dempsey from University of Wisconsin, who heads up the Foundation for International Education in Neurological Surgery, three of us wrote an article about the unmet need, the global neurosurgery. And we convened a meeting in Geneva, came up with a roadmap for action. And then one of the first action items was in Bogota, 2016 in December. We created a Bogota Declaration where we said, neurosurgeons, it is our job to make sure that all people who need neurosurgical care should be able to access neurosurgical care. We, as a profession, it should be our job to do that. And that was the Bogota Declaration in 2016. The picture on the lower right is from the Weill Cornell Global Neurosurgery Symposium in January of 2019. Parth, you were there, as you remember. And this was one of the earliest global neurosurgery symposiums that we held. And this was Roger Hartle. And since then, we've had a number of other global neurosurgery themed meetings and symposia. All right, so at the program in global surgery and social change, we have a global neurosurgery team, and we do a lot of research. And one of the first things that we did was to try to understand what is the unmet neurosurgical needs within the global surgery environment. And we came up with a conservative estimate of 5 million operations that were currently not being done that needed to be done. And by the way, more than half of this was for head trauma. And to meet that 5 million unmet neurosurgical operation burden, we needed 23,000 additional neurosurgeons right now, today. So the baselining work is done. And what does this mean then from a global surgery standpoint? Well, what we want really is the ministries of health to start including within their surgical system strengthening neurosurgical components. And so I'll get to it in 1 minute. This slide, it has to do with the WFNS being an early adopter and supporter of global neurosurgery, and they commissioned the work to count the number of neurosurgeons around the world and map it out. And it's on their website, wfns.org. And right now we have about 49,000 neurosurgeons around the world. That's the latest numbers that we have, and we're doing this every 2-3 years. So what we need to move from is the clinical aspects of neurosurgery, the actual, the patient care and technical aspects of neurosurgery, to now expand that to what are the, how do we best how do we do surgeries better, but also how do we better deliver surgical care to all who need it? And these are questions like, well, how many neurosurgeons do we actually have to meet the neurotrauma burdens in a country? Well, our research shows 1 neurosurgeon per 200,000 people. And that helps ministries of health sort of map out, and plan out how many neurosurgeons we need to be trained over the next 5, 10, 15 years. And also how many neurosurgery trauma units do we need, and how far do they need to be apart? And there's this idea of a golden hour in the US. Well, we showed from the data from Cambodia that you might have actually as many as 4 hours before you start having diminishing outcomes. So we think that you can place these facilities within 4 hours of each other. And that has huge implications in building up a surgical system in these countries. That was the first one on head trauma. Right now, we're wrapping up a second project on comprehensive policy recommendations for management of hydrocephalus and spina bifida in LMICs. The reason we chose these two conditions is because we want to make sure that the pediatric neurosurgical services were also included on top of neurotrauma cases. And this was a lot due to a lot of influence from our colleague William Harkness, and he was a major reason that we have this document. And this will be published shortly this year in about a couple of months, actually. And what we do is we take these conditions and we ask ourselves, and we scour the literature, things like what are the infrastructural requirements for the prevention aspects of hydrocephalus and spina bifida? What are the service delivery aspects? What are the workforce requirements for surgical needs? And so these are the questions that the ministries of health will need to answer. And so we can provide this information to them now. And then the last thing I want to cover is the WFNS's role in global neurosurgery. Franco Servadai, the current president, created a global neurosurgery committee. I'm co-chair along with Abdessamad El-Wabi from Morocco. And we, along with the remainder of the Global Neurosurgery Committee, developed the Global Neurosurgery Action Plan with 5 major objectives. First is to amplify access to timely and affordable and safe surgical care, neurosurgical care, to align all global neurosurgery activities so they're now in coordination rather than these sort of random events, to advance research, that specifically research from LMICs by local neurosurgeons, and assimilating all neurosurgical activity to the broader global surgery, the surgical system strengthening efforts so that they're complementing each other. And then lastly, to advocate for inclusion of surgical and neurosurgical benefit package into the overall universal health coverage package. And each one of these major objectives have a time-bound and measurable targets, and there are about 23 of them. You can go to our website, globalneurosurgery.org, and we are on track to hit almost all of these targets by March of next year, when we'll have the World Congress of Neurosurgery in Bogota. And a couple of things. I mean, one of the things that we were able to do is get a research award for researchers in global neurosurgery from LMIC. It's purely designed to empower them and help build capacity in those settings. And then, there was clearly excellent research being published prior to 2015, but when we gave it this name, global neurosurgery, sort of in line with global surgery, it gave us sort of a tribe, something to label, a keyword that everybody can use together. And I think it's made a huge difference. The explosion of articles in PubMed using global neurosurgery as a keyword has exploded. That's the good news. The bad news is that most of the research is coming from high-income countries, and we really want to encourage research capacity building in lower and middle-income countries. So there's a journal that we started called Journal of Global Neurosurgery. Maybe it's a very new journal. There are no article processing fees. There's no charge to the authors, and there's no charge for accessing there's no paywall. And we launched our first issue in September. Our second issue is all dedicated to pediatric neurosurgery, and it's dedicated to William Harkness. As you know, I mentioned earlier, he's a champion of global neurosurgery, global pediatric neurosurgery, and global surgery. And we miss him dearly, and we wanted to pay a tribute to him. So we encourage you to submit your articles to journalgns.org. The deadline is coming up. These are questions not only with these are pediatric neurosurgical research papers is what we want, but specifically we want to have you should have an angle of how do we improve pediatric neurosurgical care in the developing world. So we look forward to receiving your manuscripts, and thank you very much for this opportunity to share with you.
Thank you, Keith, for that wonderful talk. Again, lots of great points, and look forward to the discussion. That's the big picture. Really love to hear your comments on how do we start. So before we get to the questions, I'm looking forward to hear Jim Johnson speak. As I said, Jim's was one of the principals in developing Intersurgeon, and part of the section on pediatric neurological surgery's efforts to get a handle of the idea of how do we as a specialty help. And he's done a great deal of work with that, and is particularly using technology as a method of outreach. So without further ado, Jim, thanks so much for doing this. Looking forward to your talk.
Well, thank you very much, John. It's really an honor to be invited to be part of this panel. Obviously, Key has really been a real inspiration and mentor to me. And obviously, Dr. Green, for what he's accomplished with the University of Miami and Haiti is really an incredible accomplishment. And I guess what I see, what I'm talking about here is sort of kind of the smaller level approach to these bigger issues, which I think are, as you can probably get a sense both from Dr. Green's and Dr. Park's talk, kind of gives you it's a very complicated issue that is not just surgery. It's not just doing operations or whatever. And I think that we hope that Intersurgeon helps to be at least one part of addressing this much larger issue. So I'll share my screen here. Great. So I'm going to talk about social networks, augmented reality, and the evolution of global surgery training. So, like what Key recently talked about, since 2015, there's been this real sea change in how the global health community sees global surgery and how it fits into the much bigger issue of global health. And with not just surgeons saying it's a big deal, but also the World Bank and World Health Organization and the Lancet article in 2015 really kind of helped define the problem, as well as metrics and ways to go about addressing it. Like what Key mentioned, there's a lot of amazing work that's going on now, kind of helping to quantify what these shortfalls are in terms of neurosurgical workforce, surgical workforce, access to care and operations. And like what Key mentioned earlier, there's a lot of additional neurosurgical procedures that are needed each year globally, and you can imagine how that fits into the much larger issue of surgery, which neurosurgery is a smaller component of that. So when I first started to grapple with all this, as a young neurosurgeon, it was really kind of overwhelming. And how does one go about sort of, getting involved in this, contributing to this in a meaningful way? And Dr. Green, touched on this many times about the importance of sustainability, long-term relationships, education, and Key is Dr. Park has also talked about how it's not just that, it's also about working with ministries of health, working at the level of financing and governance and government level and international organization level. And so, there's kind of a top down and a bottom up kind of approach to complicated issues like this. And a few years ago, I went and spent a few weeks at the WHO kind of with Walt Johnson, who Key mentioned earlier. And that's actually where I met Key and learned a lot of sort of about this larger community. And I guess I kind of went thinking that there was a plan, that there was a large, top down type plan for how we go about, building surgical capacity. And what, Key was just talking about is it's really a complicated issue. I mean, there's, at the level of each individual country, at each of individual regions, et cetera. And obviously all of that is incredibly important because you have to have the infrastructure in order to do these things, and the commitment on the level of governments and ministries of health and in the international community to address these things. But I also felt that, this also, people have to be doing it from the bottom up. Education and surgical training is different than other medical training in that, we basically all learn from people and learn from, in our residency programs and fellowship programs, and by watching people do things and talking to them and reading the literature and watching videos and all sorts of things. And I always felt like there was a real component that requires that individual collaboration in addition to the larger policy issues in order to really address, how do you train someone to do a particular operation or take care of a particular surgical problem, and then in turn teach their trainees the appropriate way to do it so that they can build a sustainable system wherever they happen to be. And so, Dr. Mr. William Harkness, who Key mentioned earlier, was a very good friend of mine and tragically passed away earlier this year. And he always had a vision, I think, that was supported by many, but he really helped to crystallize that, which is that, what we're doing here as Global Surgery, it's really a large social network. We kind of know each other. We see each other at meetings. We read each other's papers. We have very traditional ways of interacting with each other, but it can be difficult to connect in an easy fashion, to find other people within, your specialty, within your region, within et cetera. And so we first started talking with individual organizations, the WFNS, the American Association of Neurological Surgeons, and all of our other national organizations who all do some things very, very well. But we found that it was somewhat difficult in order to take advantage of their networks or their memberships in order to connect people who are doing global surgery. And so what we decided to do with others was to raise some money and basically build a software or an application that would be free to all. And it was built basically as a decentralized social network architecture that could handle literally hundreds of thousands of members, where, like Facebook or Airbnb or Yelp or other things that we use in our day-to-day life and our smartphones, we'd make it a community where people could basically make profiles and then find each other based on clinical assistance, education, equipment, training exchanges, and then even research as time goes on. And so we built a site. I urge you, if you haven't already heard this talk or been there, to check it out. It's called intersurgeon.org. And basically you establish a profile on it, just like you do on Facebook or LinkedIn or whatever else you use for these kind of network kind of applications. And then you create a profile based on what your background is, what your skill set is, what you're looking for, what you're looking to learn, what you're looking to teach, languages you speak, et cetera, et cetera. And you can put videos and pictures and everything about wherever place you happen to be working, or places that you've worked in the past, or et cetera. And then you're able to become an entity on the community, which other people can find. We have an algorithm that helps to match people, but then also the ability to just browse on your own by various criteria on the map, et cetera. And the basic principles of Intersurgeon, which Dr. Harkness was very adamant about at the beginning. So this is a free service. It's independent of any particular organization or subspecialty. There's no advertising. It depends on donations. Like I mentioned, its members create profiles and offers and requests, and their identity is validated. We have a panel of champions that does that, which I'll talk about in a second. Like I said, we have an algorithm, we have a map, we have search criteria browsing that allow people to find each other. We now have free Help Lightning augmented reality software, which all of our members get for free, which we've entered with a partnership with a company that provides that for us. And we've been relatively successful over the last couple of years, just organically and based on word of mouth. We have over 800 members from 100 countries. Many of those, over half of those, are neurosurgeons, but the largest and fastest growing component of our population now is non-neurosurgeons, other surgical subspecialties, anesthesia, and more recently OB. We have a panel of subspecialty champions that a lot of them were friends with myself and William, and we knew were involved in global surgery. And so they've all been kind of brought into the fold to work on recruiting membership within their subspecialties. Like as we mentioned before, we really are working to ensure that we have appropriate representation from LMIC surgeons on Intersurgeon. And so we welcome people who are interested in working with us as champions for recruitment within their subspecialties from all over the world. These just happened to be William and my friends who we were able to convince to get involved. But like I said, we created this as a world within a world in order to help expand that network of people doing global surgery. We've also kind of created this, I like to think of it sort of like a coral reef of partners, of people interested in this ecosystem of global surgery and global neurosurgery, with partners from the United Nations, the G4 Alliance, which is a consortium of about 85 academic institutions and NGOs involved in surgical capacity building. Foundation for International Education in Neurosurgery, the Pediatric Neurological Surgery, the section, which has been an important supporter of us, UAB, where I am, and Ohana One, which I'm going to talk about in a second, which has been a very important partner for us, especially in the rollout of augmented reality technology for members. I think what this all points to, or my theory in all this, is that in addition to the things you've seen already from Dr. Park and Dr. Green, I think that there's a slow evolution in global surgical training paradigm that is sped up quite a bit since the pandemic, which is that we're sort of seeing a move away from the traditional ways of, people flying back and forth and doing mission trips and doing those kind of face-to-face type of interactions, and looking more and more towards digital collaboration. I mean, we all use WhatsApp, we are all using webinars and Zoom, obviously. And what I want to kind of present to you all is that there is cheaper and cheaper and better augmented reality solutions now that are making this kind of surgical and clinical interaction a reality. Like, you don't have to have $100,000 setups from Microsoft to do some really cool and effective interactions between surgeons and clinicians to improve surgical education on the individual and institutional level of surgical training. So I guess, like I said, is that I think this really fits into that whole, Foundation for International Education Neurological Surgery. Bob Dempsey has talked about this for a long time, this dyad model, where you have these long-term relationships between mentors and mentees, whether it's an institution or an academic institution, or it's a particular neurosurgeon or surgeon who has developed a relationship over time with a hospital or health system. Because, like what Dr. Green has mentioned earlier, this is not something you just do fly by night. These are things that take years to develop, and the relationship is very important to understand exactly what's going on, what are the needs, what are the issues, not just at a hospital level, but at administrative health level, that partners can work together on to improve over time. There's obviously visiting fellows programs, which have been a very important component of things. There are traveling fellowship programs where people can spend time in the United States and Europe to get, more advanced training in, let's say, pediatric neurosurgery, which I think is a very important component of all this. Webinars, Zoom conferences, virtual boot camps, case sharing on WhatsApp. We've all seen these things really improve our ability to do didactic type training and talking and answering questions, and like what we're doing right now. I think a very important component of that. And I guess I would submit that the next component of all this is augmented reality mentoring, where you can have more one-on-one mentoring that's not just 1 week a year or at a Zoom conference, but actually in your clinic or actually in the operating room. So we worked on this a few years ago here at UAB, working with some partners in Ho Chi Minh City, and kind of adapting some commercially available augmented reality software that you could use for smartphones and for tablets. And we found it very useful for neuroendoscopy. We worked with the Children's Hospital No. 2 in Ho Chi Minh City. We're the chief of neurosurgery there, Dr. Tan Kan Dang Do, who's a very well-trained neurosurgeon, but was just sort of at the early stages of setting up a strong pediatric neurosurgery program with some things that were not a traditional component of neurosurgery training in Vietnam. We were able to kind of use this to sort of bring him, as well as some of his younger neurosurgical colleagues, up to speed with neuroendoscopy. We found this was not something you do like the first time you learn how to do an ETV, but this is something where you've done ETV, you've watched people. Dr. Khan had spent some time with us here in Birmingham, but then when he went back, we were able to kind of use this to sort of help finish his confidence level to do more complicated ETVs. And we found that it was very, very, very useful for decreasing complication rates, making him essentially as effective as we are with our ETV CPC here. And we kind of knew that it worked really well because after about 25 cases, they just really stopped calling us. They didn't really need our assistance with ETV anymore. We wrote this up and found it to be very useful for ETV, as well as some microsurgery cases in terms of, helping with identification of anatomy and some things like that. The trouble with this is that it's really set up for endoscopy or laparoscopy, or things where you have a screen or an endoscopy tower that you use for your augmented reality, and it didn't give you that hands-free type use that you would use for a lot of basic neurosurgical cases and in the clinic and whatnot. So I think that what's really exciting is over the past year, Intersurgeon has entered into a really cool relationship or partnership with Ohana One, which is a nonprofit, a surgical education nonprofit that's out of California. And they've really had this vision for a while, which is how do you use technology to improve that one-on-one type surgical education. And they have basically set up a really interesting program where they have these Vuzix smart glasses, which are relatively inexpensive smart glasses that will run Help Lightning, so this augmented reality software. And we are sort of working with them to do a larger study to look at feasibility and whether or not this actually helps with surgical training or not. And they're using this OSATs, which is a validated surgical technical proficiency survey, which is worked out in general surgery, to basically do surveys throughout at the beginning and every few months over time to see how people are doing in terms of getting people up to speed. And the way that this works is kind of the best way to talk about it is that the reason why it's good is because you don't have to be flying back and forth. A pair of glasses costs about $1,500, which Ohana One is covering for this study. It allows you to have virtual mentorship that's basically year round. You send the glasses to your partner, and after some training, get things set up, make sure that they have a hotspot in their operating room or Wi-Fi setup that supports basically Skype level video. And then basically every time that you want to work together, you just set up an appointment, and then you go and you can either meet them in clinic, virtually, or you can be in the operating room with them, et cetera, to work on discussion, pointing out things, et cetera. I'm going to give you a little example of how it works. But the idea is that you're actually there, as opposed to, it's not just a lecture or just a typical didactic experience like we're all really used to. So just to give you an example of how this works, we're using these glasses with our same colleagues, Dr. Khan in Ho Chi Minh City, because he wanted to set up a more complicated craniofacial program at his hospital. So like I mentioned before, we've had a long-standing relationship with him and his group. We've made regular visits to the hospital in Ho Chi Minh City and helped him establish his programs in tumor, spina bifida, hydrocephalus, vascular, and basic craniofacial surgery. We also have a global fellow program at Children's of Alabama where we host short-term observational fellowships for his trainees in neurosurgery, but also other services at his hospital, including neurology, epilepsy, neuropathology, nursing, and EEG. In addition, we'd kind of do our normal Zoom conferences and case sharing and other things like I know a lot of other places do. The way this works is we send him these glasses. You can see he's wearing them here. And basically he gives me a call, and I'm on Skype, and we say, yep, let's start it up. And then he basically calls me, and then it rings to my on Help Lightning onto my tablet, and I basically can see what he's looking at. So basically he usually calls me after he's done the exposure for a craniofacial case. What's cool about this software is you can have more than one person calling in. So I do this with my craniofacial colleague, John Grant, who's a plastic surgeon here at Children's of Alabama. That's him up in the upper corner. And I'll just run this video for a little bit just to kind of see what we're seeing, and I'll kind of talk you through it as we're going. So the sound is messed up, so I'm gonna just mute it for now. But basically we're talking back and forth. It's very social at the beginning. How's your family? What's going on? Catch up on the case. He'll look at what he's doing, show the exposure, and then we can actually freeze the image on our iPads, and then we can draw on it. So we found that's kind of the easiest way to do this. And we'll draw, like in this case, here's what we're trying to accomplish. Here's where some of the cuts are going to be. He's asking us questions as we're illustrating. We're explaining, so here's where this is an older patient with a craniofacial multi-suture synostosis, and we're helping him kind of do an expansion procedure. Then we can watch him as he starts to work, and then we can pause it again and say, well, yeah, now that you've made your cuts, here are some options of how we would do this, and we would cut this bone out here, and these can act as struts. which is really difficult to convey if you're just talking to someone about it, or if you just read a textbook about it or whatever. But if you have a real life surgeon who's illustrating it for you while you're doing it, it's really remarkable how much better the training is. With the way we say it is that, like, a picture's worth 1,000 words, a video's worth 10,000, but a video where you're actually in it with them is worth even more. And that's what, you know, the experience we've had with our colleagues in Ho Chi Minh City, and then Dr. Brandon Rock, who's one of my partners, he's doing a similar study with the National Cancer Hospital in Hanoi. Is a very similar kind of experience. So it's hard to convey it, but this is kind of the general sense. We're watching video, we're talking, we're freezing, we're illustrating, we're talking it through, and we're proceeding with the surgery. So we've done about 5 cases in the past month. We literally just started this, got this running about 4 to 6 weeks ago. And like I said, we're working on craniofacial cases. Dr. Rock is working with Dr. Lien in National Cancer Hospital on some kind of more complicated hydrocephalus techniques. But right now there are 5 neurosurgery partnerships that are working right now. So 10 surgeons or 10 institutions total. There are 2 here at UAB in Children's of Alabama. Dr. Jack Rock, who's at Henry Ford, we're using glasses to work with his partners in Myanmar, although that's been delayed because of some conflict issues in Myanmar. Dr. Roger Hartle, who was mentioned earlier, is using these with his longstanding relationship for spinal training at the MOI in Tanzania. And then Moody Qureshi, who's a Kenyan neurosurgeon who has been very involved in global neurosurgery. He is using them to do some mentorship with some of the regional hospitals that are around Aga Khan in Nairobi, Kenya. So what we're hoping is that over the next 6 months, with using these glasses, we'll be able to kind of establish, what's the feasibility, how useful it is using this validated outcome study for surgical proficiency. And like I said, hopefully this will be something that we'll be able to kind of publish and put out there and say, listen, this is more cost effective than plane tickets. And this is a really valuable technological thing that we can use to kind of augment our existing educational paradigm to increase the ability for us to do surgical training with true sustainability over time, which I would argue is one of the hardest things at this surgical training level in global surgery. So I'm happy to answer any questions you have about Intersurgeon or the project with Ohana One and the augmented reality. If you don't mind, we just started our LinkedIn presence with Intersurgeon. If you're a LinkedIn person, go to our site, invite your friends to it. Tell your friends about it, not just in neurosurgery, but in surgery in general, anesthesia, OB, because we're rapidly trying to build our partnerships in all of those fields as well, which I think will make us more useful to everybody and provide a resource to be from the bottom up to what Dr. Park's doing and try to maybe improve, and make it more easier for people to make the collaborative relationships that have been so successful, like what Dr. Green is in Haiti, and not make it, as unique as that is. So thank you again, and I'm happy to answer any questions.
Jim, thank you very much. That was a wonderful overview. We have some questions that are already have been sent in by the participants. There's been a great deal of interest, obviously, and I don't want to monopolize all the questions, but I can't help but ask, Jim. I mean, I think the technology is a wonderful way to create a bridge between us and our trainees. But the bandwidth and the access to the internet at our hospital in Port-au-Prince is really quite poor. It's so bad that you really can't even do like a FaceTime or Skype kind of talk. And I just wondered if on the big picture, there's any vision for how to improve internet access to lower and middle income countries and eventually into rural areas to be able to extend our reach. I'm interested in your thoughts and Keith's thoughts on that. How do we get access to help our trainees globally?
Well, I totally agree with you, John. I think that's an issue it's bigger than just augmented reality, right? I mean, access to the internet is a huge developmental issue for our time. I mean, economic development, education, et cetera. I will say that over the past 5 years, there's been a sea change in terms of how that has become so much more available in the places that I've been talking with, Wi-Fi is not nearly as important as just the LTE service that's now become so much more widespread. Like talking with Marshall Sellers, who's the executive director at Ohana One, they have 50 teams, 50 teams that are going. And she said that the vast majority of them actually have adequate connectivity for this, which I thought it blew my mind. I told her, I heard she'd tell me like 10 of them did. And she said that they have a combination of Wi-Fi in some places and hotspots in the majority, which have been working quite well. Now that said, it's just like everything else. It's not 100% of the time. There's different things you have to do to sort of, play around with, like that freeze frame feature that we use is very important, because sometimes the bandwidth can go a little weird, but if you hit the freeze frame, you can do a bunch of work on it, and then it goes back to live again, and it actually, audio is good again, and you can do it. So I agree with you, that's an issue, but I think what's exciting is that because of the new software that's out there in terms of buffering, and with the relatively low bandwidth that's required, this stuff is going to become more and more reality over the next 5 to 10 years.
Fantastic. Well, I'm gonna write to you and see if we can't try again for our work in Haiti, since travel's been tough.
I'm going to encourage more people to write in with questions. We have a couple so far, so I'll ask one of them, and then I'll turn it back to Dr. Ragab to ask another question to the panelists as well. So our first question came from, hopefully I'm pronouncing this right, Dr. Damien Lastra, who reports that he's a Cuban neurosurgeon currently working in Gambia in Africa. And there are many neurosurgical diseases, but there are no neurosurgeons in the entire country. In the whole country, they have only 3. 2 of them are Cubans, and he says they do their best, but it's very difficult due to the lack of equipment for neurosurgery. He's wondering if there's anyone focused as an organization in the United States to contact about equipment agreements and trying to get more equipment to developing countries that are restricted by this issue. I don't know if any of you have thoughts.
So, I'm happy to give a little bit of advice from being in the same situation where equipment is a challenge. There are some organizations that take donations of used equipment. Dr. Green has cautioned us already about the value of used equipment that's being discarded. But this is supposed to be serviceable used equipment, which they then process and offer for donation. The name of the organization evades me. There is one for both pharmaceutical and disposable medical supplies, as well as durable medical supplies. And I don't know whether there's an email contact, but if the neurosurgeon from Gambia sends me his contact, I will be sure to find the name of the organization and email him back. Maybe Key or Jim or Barth have any other suggestions?
Yeah, so there's also an equipment donation program through the World Federation of Neurosurgical Societies, the foundation. So they have a drill, a power drill. They have a number of instrument sets from basic craniotomies and then spine sets. They even have endoscopy sets that they provide. So that might be a good place to start. It has to be a public hospital, generally speaking. So, I'm happy to, I'll put my email on the chat. That way, Dr. Lastra, you can reach out to me. I can connect you to the right people.
There's Project Medishare, not Medishare, that Dr. Green and Dr. Raga have been involved with, but Medishare, which is one of the largest ones that I'm aware of, and they do a lot of that type of accepting medical equipment and donating it. But again, like what Dr. Green had said and Dr. Raghav's mentioned, that it's a complicated issue, because just getting the equipment, especially if it's used, doesn't have all the reusables, and you don't have the biomedical engineers to maintain it, to make sure it's in proper working order, that obviously can be a big issue. But I know it's a very difficult, Dr. Lastra, to do any of this without the equipment. And that's obviously at the bigger level of appropriate financing, what Dr. Park is working on, and commitment at the level at the Gambia Ministry of Health. Do you know anyone in the Ministry of Health, or have you been involved at all with policy in Gambia? Something to talk about. Key, can you talk a little bit about that, about how someone like him, like Dr. Lester, can get involved at that level, and how you recommend doing that?
Yeah, so typically you need a champion surgeon. So it sounds like we have one. It should be a local person, but it sounds like there aren't any to begin with. And then you need to develop a coalition of like-minded people. And then hopefully you could engage with officials within the Ministry of Health and saying, hey, so the resolution 6815 for the surgery resolution was passed unanimously. So if Gambia is a member state of WHO, they signed on to it. So you can use that as a leverage to, open the door saying, you signed on onto it, what are you doing about it? So that's probably a good place to start.
So, along those lines, I was hoping Dr. Green would comment. I can remember over the years, many people telling me to not deal with the local government because you'll never succeed. And, we just heard from both Key and Jim how finding a local partner and champions are so important. And I think Dr. Green's experience with this is valuable for those listening. Perhaps, Barth, you could tell us about your experiences working within and without the government and the importance of partnership as you see it.
Yeah, I think there's no doubt that partnerships are important, and there are organizations which are global, like Food for the Poor and others that go all around the world, Direct Relief International, and deal with pandemics and other issues. But as far as the government itself, unless you develop a relationship with the Ministry of Health, you're not going to be included when opportunities arise. In Haiti, for example, the CDC, the USAID, that type of funding is very political, and it's decided by the Beltway bandits in Washington, nothing to do with what you're doing in Haiti. So you've got to decide whether you're going to become proactive and go to Washington. I used to go all the time and testify, and then I would become audited, and Medishare would be audited, and I'd be punished. But it's important to speak out and be honest, but also to try and outsmart some of the challenges that we face. But if someone like that has an individual problem in a country, I'm a soft touch. And if they tell me what they need, I might be able to know a guy who knows a guy and help them. And I think a lot of us on this panel might be able to help them too. We're using the augmented reality at our trauma center at Bernard Mev now, that we're working with an NGO out of USC, and it's working pretty well. But again, you're right. There's no power except generator power most of the time in Haiti. And that's part of the issue. But I think a lot of countries like Vietnam have amazing power grids and internet and connections. And other nations like Gambia and Haiti probably don't have the infrastructure, the digital infrastructure, but that's definitely the future. And when I heard that about guiding the surgery, I've been working with upstart companies now coming out of the development stage that are working exactly in that area with these glasses that will be able to focus surgery, because the augmented reality glasses available so far give you a straight on look, but they're not good for focusing in an operative field. Is that what you find also? Or I'll ask the other panelists, but it hasn't, I don't think the commercially available units have been refined to the point of.
Yeah, no, I totally agree. The version we're using, we're working with the company to help do some modifications to make it much better for surgery. Because I agree, it definitely, it's kind of it's not you can't zoom in. It's not good for looking at really small things, and it's a little bit off to the side. And so the next generations are going to be much more built for surgical applications. So I agree with you. It's exciting that you're working on that.
Yes, we'll have to talk offline about it. But there's so many opportunities because in the tech world, there's a lot of money. And companies like, Apple and all the big companies, J&J, They're pouring billions of dollars into these technologies. And so it's our job to convince them that part of this activity should go for global health and global surgery, because they're working on the technology and we can beta test it in your different centers you're working on now.
I'll ask another audience question and then we'll go back to Dr. Agab. Dr. Caitlin Morris asked what I think is a very important question to keep in mind. So she asked, to what extent is a lack of post-surgical neurocare a variable in being able to do the surgery? This actually reminds me of a story I know of with a pediatric neurosurgeon who worked with Dr. Hartle, and they did a craniopharyngioma case and did not fully take into account the postoperative management, DI watch type issues and ability to actually get DDAVP in Tanzania. They had thought they had access and did not, but I'd love to hear the panelists' thoughts on that, because I think that's a very important question.
You know, I'm sure I'll let the others chime in. I think Bart's had a great deal of experience with this. I've heard his story about handing out antihypertensives and anti-cholesterol drugs many times. Maybe the rest of the audience would appreciate hearing it, Bart.
All right, the classic medical missionary, which makes my hair stand up, would fly into Haiti with a hat, a t-shirt, cameras, and a month's worth of blood pressure medicine or antibiotics. And they'd go into an area and everybody's blood pressure would go from 180 to 120 for 30 days. And then we'd have to go up there because there'd be a massive outcome of strokes, you know, just reactive. And that's the problem with medical missionaries. If you're going to go into a program, if you're going to commit to a country or to an area with pediatric neurosurgery like Dr. Ragab, you've got to set up follow-up. You've got to take that responsibility. Make sure when you get on your plane and fly away that somebody's taking care of those infants and their families, because the families need a place to stay, they need to eat, they need to be next to their children, and it's holistic. You can't just, you know, have the glory of doing the surgery. I remember all the missionaries coming back saying, I did 15 craniotomies or I did 20 shunts. And I said, well, what happened? What was your outcome? And they can't tell you because they never went back, but they have a lot of pictures. So that's what John's talking about. It's you know, it's very important not to start something you don't finish, and make sure that these people are treated with the type of integrity that you would want for your own family and your own children and grandchildren. That's important.
Yeah, I totally agree, with Dr. Green, and I would submit that the surgery part of things is actually the smallest component of this big question. Like what we try to think, or, you know, that people who've, you know, influenced me and taught me is that, you know, we're not really surgeons. We're not just doing surgery. We're basically just taking care of things that happen to be surgical diseases, but it's a much bigger issue. So any sort of, you know, educational endeavor or training endeavor you do, you know, you got to make sure that there's a nursing component, that there's a pediatrician component, that there's, you know, all sorts of things that go into that, because, you know, otherwise you're just sort of, you know, you're a cowboy basically just out there. And I think that that's and a lot of surgeons, it's hard for us to think about that, right? Because we go to work every day and we have this incredible system that's just there to help us succeed. And if you're going to be doing this kind of work, you really have to look at it at a much, much larger institutional level. And I think that's a very important component.
And there's a player globally called a community health worker who lives in these different rural communities and really can be your contact from the post-op patient to the surgical center. And they live with these people, they work with them every day. And so that's what's worked so well in Haiti and the Bahamas and other areas where I've done this type of work in disaster response. Important component.
I agree. It's a really super important question, and I think he's spoken to this issue in the past, and perhaps he could add a comment here. I mean, you know, as we think about surgery, to be able to accomplish safe surgery requires more than just an operating room and a surgeon. And I think that's why the global effort to develop surgical care, it has to take all of this into consideration. I know that's a really super important part of what Key's been working on. And maybe you could just add to that, Key, because I know that's a big part of improving global surgical care.
Sure. So, we all trained in an era where technical experts were the gods, right? In neurosurgery. I mean, whoever can take out the tumor that's in the most difficult place, and the video of the patient afterwards, it's like, all right, he's the best surgeon. And I think that's fine. And we should try to strive for technical excellence and mastery of technique. But that's not enough. And so we're paying the price when we focus on the technical aspect of surgical care, because we go and train on the operation itself and don't really deal with the complications that could arise. And in Ethiopia, I had a spectacular failure where we just taught the technique, and it was just that is not surgery. I mean, that is not surgical profession. That's just the hand movements that go with it. So yeah, I think it's important to invest the time and the effort to build up the whole system. And this is why I think the global surgery movement is such an important thing, because we approach it with nursing care, infrastructure, information management, the safety aspects, affordability aspects. So there's all these dimensions that we have to address, not just the surgical technical aspects.
It's just so important. And for us in neurosurgery, if you're going to take out a craniopharyngioma in a child in a lower middle income country, you need to know that you can provide postoperative care in an ICU environment, endocrinology. Same thing is true if you're going to manage spina bifida. If you can't manage the child's bladder and their lower extremity deformities, you haven't really taken care of the child. So I think the concept of how we look at advancing global surgery is more than just the operation. It is the entire process of managing the surgical patient, the whole soup to nuts. So I really think this has been a spectacular session. I really want to thank Barth Green, T. Park, and Jim Johnson for their time and their really wonderful talks. I could keep asking questions, but Heather is waving at me in the background, and Toba's told me to stop. So again, thank you so much for doing it. It was really wonderful and inspiring, and look forward to seeing you guys in person someday soon.
Thank you so much to everyone. This has been an absolutely great discussion. I look forward to seeing you guys in October for our next session.
Thank you, Heather.
We'll send out a video link as well. We'll post that online. All of these sessions are available afterwards on YouTube. So if people want to watch them, or colleagues haven't had a chance to join in today, they can watch it there.
Thanks again, everybody. Stay safe.
Thank you.